Thank you everyone for joining us today for an easy way to reimagine peer review. Today we have two fantastic presenters. We're joined by Jerrod Bailey, CEO of Medplace, and Terri Schimmer, an RN, former risk leader at Cherokee Regional Medical Center. A little bit about Jerrod. He can give some more background into his experience, but 20 years of experience in venture-backed technology. He's an expert operator in healthcare technology development and human-centered design. A quick note for you guys, if you can take a look at this slide here, we will be doing some polling at the end of the presentation. To access the poll, you can either go to menti.com and enter the code there, or you can scan the QR code with your phone and that'll take you straight to the page where you would sign up for the polling. It's 4 quick questions, and we'd really appreciate if you could participate. Again, either go to menti.com and enter that code, or scan the QR code there. And on that note, I will turn it over to Jerrod.
Great. Thanks, Nestor. Hey, everybody. I'm Jerrod Bailey. I am the CEO of this company called Medplace. I think everybody got here through an invitation from Constellation. There's a bit of a backstory, I think, there that's interesting as well. But I'm also joined by Terri Schimmer today. Hey, Terri. She might be on mute. But I will give you a little bit better introduction here a little bit later. What we're going to talk about today is peer review, how it relates to risk, and in opportunities with peer review that are available now that I think you guys will find really interesting. And rather than me tell you how interesting it is, I thought it'd be great to have one of your peers on, and that's really been working with Terri for the last year on Cherokee's peer review process. And one of the things I say is, there's really nothing. There's few systems like peer review that are more capable of enhancing delivery of care by making very small incremental changes to it. And if I told you, if you change your peer review process by about 1%, you could probably double the efficacy of it. That's what we're going to go into today. So let's kind of unpack peer review really quick, just to kind of lay the foundation. And then I'm going to start to paint a little bit of a vision of what that might look like. A 2.0 process might look like, and Terri's going to give you some actual boots on the ground experience with this 2.0 type of approach. So with that, Nestor, if you could take me to the next slide. So it's interesting. I come from a technology background. I've done a lot in healthcare and other spaces. I come from a human-centered design background, and that means less technology, more humans. Really designing technology around the people first that need it, and then you get into the technology after that process. But it's important when you look at something like peer review, which is involving a lot of humans and a lot of people with experience and a lot of teams that have team dynamics and things like that. So peer review is this really interesting, important process that is carried out by humans, right? And there's actually an opportunity for technology to come into the middle of that, and I'll kind of show you what that looks like. But what are stakeholders saying about peer review? So it's important, but what is everybody saying about it? So Nestor, let's go to the next one. We Medplace work with doctors all around the country. We have about 650 doctors on our platform from every specialty you've ever heard of. They're all around the country. They're in, big hospitals, little hospitals, clinics. They've got usually 10 years or more of experience, and they're very, very talented people. They're people just like the physicians that you're working with every day. And we polled them because we were looking initially at how do we facilitate or come in with solutions for the peer review world, and it was really not great feedback, I guess. A lot of doctors will recognize that their peer review process is important, but when you really ask them without any microphones on or them, having to answer this question to their team, a lot of doctors feel like the process is not as effective as I think we're all hoping that it would be. And a lot of times you get words like political and bias and things like that put into the process. Sometimes it's weaponized against them. Often it's a reactive process because, it only happens when things go badly. And of course, that's a natural place for peer review to come in. But peer review that's done more proactively, we found when just working with hospital clients, it's a very different mentality. It becomes less punitive and more about quality of care and about increasing the systems and quality delivery as time goes on. So next slide, if you would, Nestor. The carriers, so the medical malpractice insurance carriers, it's important to them. This quote came from somebody who's a risk manager at a top 5 carrier, and she said, "When it gets to us, we're already down the line and bad things have happened. I'd like to see our hospitals doing independent reviews earlier." And independent reviews is really the key, and that's where we're going to dig in here. Independent reviews are hard to do. If you've ever tried to do one outside of your employed physician group, every one of us, if you've tried to do that, has probably been ghosted, as we say, by a well-meaning specialist working at some other hospital. So how do you make that work? And how do you do it at scale is really important, but it's important to the carriers because they're at the downstream risk level, right? They'd love to see more independent reviews done earlier. And that's a little bit of the backstory, and I'll segue here a little bit. One of the reasons that you heard from Constellation is Constellation actually started developing this idea of Medplace a few years ago. They really care about their physicians, and when something bad happens, even if it's not a claim or a lawsuit, they really wanted to be able to come in quickly and early and be able to come alongside their insured doctors and be able to give them independent reviews fast, something that would assuage their fears and really establish for them, the facts of the case and things like that, so that they could continue to practice medicine and not have the burden over them. So they do a lot of early resolution and things like that. Well, that necessitated them to use some technology because it was taking months to get a review done, and they wanted to do it in a matter of days, at most a couple of weeks. So that's actually where some of the genesis of Medplace came from. Now, we've worked with other carriers and hospitals since then to develop what we've got today, but I want to let you know that there's really a lot of empathy and heart behind why Medplace even exists. But as we matured as a company and as we've been doing these reviews at the carrier level, it became obvious that we could push further into the hospital systems themselves and be able to make something that has become very easy for the carrier, be able to bring something like that to the hospital level. And Terri will give you some idea of what that feels like. Next slide. So administrators, what are they saying? Well, 25% of administrators can't recall basic peer review metrics. It's very common that, peer reviews have become this sort of rote thing. Don't necessarily know what's coming out of it. We're not necessarily happy with the data and even trusting of the data that's coming out of our peer review process because of some of the system design flaws in it. And we'll address those here in a second. And then only a third actually track process of care improvement, right? Peer review is really about and should be about improving the delivery of care, but often it doesn't get that far. Often, it's not serving that function. So next slide. And this is from PubMed, peer review accounts for 18% of the variation of quality and patient safety. That's a massive number. There's not a lot of things that have that type of effect on patient safety and quality. So here's this really important system, and we all have to do it because Joint Commission and others say we have to do it. We're all involved in it, and yet there's some components that if we can just tweak those a little bit, all of a sudden we can unlock a lot of the opportunity with peer review. Next slide. So peer review today. This is from an article on the left side here. Peer review of physician clinical practice has existed essentially the same form for more than 100 years. That is in fact true. I think we've all seen it. We've all been passed down a process that was started years before us. We can continue that process today. But we'll find that oftentimes, and this is not always the case with every hospital, but oftentimes it's rigid and prescriptive. We oftentimes complain that it's reactive and punitive. We We acknowledge often that there's cognitive and professional bias involved with it. There's also some unfairness that can be exposed, and that can be exposed through litigation and things like that. And more than anything else, I think we've all been through it. It can be slow, and mostly because it's under-resourced, and it's just resource intensive to do peer reviews in general. And then you start talking about independent peer reviews and going outside the physician group, and it just goes off the rails, right? It's just there's a lot of moving parts and not enough people to keep it going. Next slide. So why does it matter? Well, peer review underpins our entire delivery of care. Bad data hides risk. So we're doing things today in clinical practice that are risky behaviors, but we don't necessarily know about it because it's not being exposed through our peer review process. And that just means that we're building up harm events and risk events that are going to come later, maybe years later, when we could be figuring things out now and really improving quality of care. Reactivity never really gets to real improvements, right? It usually ends up being stopgaps. If it's called unfair, we might find out that we've got, one, we may have legal action, but even before legal action, we find that we've got doctors that are not happy. They're being reviewed by people that they don't consider peers. They're being reviewed by partners or competitors, things like that. And this idea of this doesn't feel fair is an important one for us to address, and I think an easy one for us to address. And then if it feels punitive unfair, then the less things get reported, right? So these are all things that I hope we can address. Some of it Medplace can address. Some of it we address through our philosophy. How we operate as a hospital or as a clinic is important to that. So next slide. So resource constraints, right? So everybody's stretched thin. It's been particularly bad the last couple of years. We ask our doctors to do peer reviews, but it's not compensated work. So it's kind of like it ends up being the last thing on their plate that they do. They may not necessarily pour over it the way that they might if they were doing something else they were being compensated for. But that's a reality of what we're dealing with, right? We all buy into the process, and everyone expects doctors to peer review each other, and that's normal, and that's right, and that'll continue. Limited access to the right subspecialties. Yeah, I've got a great OB-GYN, but I don't have two. And when I need to peer review my OB-GYN, I don't really have a lot of good options to do that, right? So where do I find these specialties if I need to? And then usually we have one man or one woman armies kind of running all of this stuff on top of a lot of other duties. And Terri is one of those one person armies, but many of you are as well too, right? So it becomes very, very difficult to manage a lot of these moving parts and to get over some of these constraints. Next slide. We talked about the legal exposure of this. That's another thing that we want to be able to avoid, right? We want to be able to do things in a way that is defensible if if it leads to actions that we're taking, right? So we want to be able to do things that show a very unbiased approach. That's why carriers do independent reviews all the time when they do things like claims, is because they want to be able to show further down the line that they removed bias and things like that, and they did these things properly. Next slide. I talked about bias, so there's kind of two kinds of bias associated with peer review. There's the bias that we always bring in, right? Cognitive bias, we bring in hindsight bias, right? Oh, now that I know the outcome, I judge the care that was delivered, right? Those are really easy things to do. We do them naturally as humans, but they if you're on the other end of that, if you're the doctor that's being reviewed and you're recognizing that there's a lot of armchair quarterback type of stuff going on, it can be very difficult, right? It's going to be a natural part of every peer review process, even independent peer review process, but we can account for that, and we can, if we are accounting for it, we can help prepare the reviewer to really try to look a little bit more independently outside of these lenses. Now, there's another kind of bias as well, and that's the next slide. And that's the social biases, right? So we're in the same work group, or we're competitors, right? We have to show up in and work with each other every day, right? There's just an inherent, when I talk about system flaws, there's an inherent system flaw in that, because I care about my relationship with the people that I work with every day. Doesn't mean that I'm going to throw them under the bus during a peer review, but it means that I'm always sort of consciously or subconsciously checking what I'm saying. And there's big personalities in what we do, and there's all sorts of other stuff. And knowing that going into a peer review, it's going to paint how much critical feedback I'm actually able to do within that, right? So it's a bias that we want to try to mitigate. We also get into groupthink, right? Or we've always done it this way at our hospital, and that's what we know. And it was established a long time ago, and I don't know why, but I do it today, right? So there's kind of all of that we're dealing with, right? And if we don't create the opportunity for new ideas to get injected into that, then we sort of miss all of those opportunities, right? So we want to account for that. And then whether consciously or unconsciously, many of us often are displaying bias, whether relates to race or sex or sexual orientation. Those are just things that come with being human sometimes, and we're all on a spectrum of awareness of that. So the question is how much is that playing into what's going on here when we're doing our peer reviews? Next slide. And then limited, right, or reactive, right? So the reviews might be limited. They're based on bad outcomes, where I've seen hospitals that actually are so proactive that they just automatically look at procedures that were done. They take a percentage of everything that's done. They do a percentage of those internally. They do a percentage of them externally. And it's really a proactive process. And what that does is it avoids the whole getting lucky thing, where it's like, hey, nothing bad has happened, so we'd never review this, either this physician or this procedure or whatever. And really, we're just getting lucky, right? There may be a bad practice that's been going on maybe even for years, and we just kind of got lucky because nothing bad has actually been reported yet, right? But if we create a system that's easy to use, it creates the ability, opens up the opportunity to start being more proactive and start actually seeing some of those patterns before they become issues. And then ultimately, we're reactive because we're resource constrained. So oftentimes something bad happened, we want to get an independent peer review done. 6-9 months later, we're actually getting it done. That's way too long, right? It's too long for the provider involved, too long for everybody. So, we want to be able to try to design systems that make it really, really fast to do that. Like how can we get reviews done and get eyes on some of these things independently within a few days instead of, months? Next slide. So I want to sort of paint a picture for everybody of a peer review 2.0 process, and it's really simple. It's taking 1% of our reviews and it's figuring out how, and it's implementing those independently. And we'll talk about the power of that. But it really can transition us from being rigid to being flexible, right? From being reactive and punitive to proactive and improvement focused, right? It can get us from where we're at today, which may be a lot of bias, into a place where that's really not even an element anymore, or it's mitigated substantially, right? Protect ourselves, be able to create a proper, defensible process for when we get reviews done, and ultimately make it easy, right? Let the army of one, those RNs of you who are out there managing your risk, or those of you who are managing your, the medical committee and staffing, be able to say, oh, this actually can be the easiest thing I do all day, not the hardest thing that I do all day. Next slide. So we talked about what's getting in the way. What I thought we would do, actually, let's jump to the next slide. Yeah, so what if it was easier? Let me paint you guys a picture, and I'm going to do it with my friend Terri, who's joined us. Can you jump forward, Nestor? One more, because I think we've kind of covered all this stuff. Yeah, we're going to talk about a new approach. I'm going to give you guys a vision for what independent reviews could look like. And the person that's going to help me is Terri. Hey, Terri, are you with me? I know we were having some audio issues earlier, but if you're talking, I can't hear you. I'll give Terri a second. She might need to dial in. So she's got some
Let's give
internet
Terri
problems
a
there.
second, and then I think we
Perfect.
can, you can share your screen, Jerrod.
Okay, good. So yeah, while Terry's getting on, I am going to show you guys what this looks like. So let me get my screen ready, and then I'm going to start sharing. All right, I'm ready to go. Nestor, if you could tell me when you can see my screen.
Yep, I could see that.
You got it? Okay, great. So imagine that you need to get a review done, and you want to do this independently, right? So you need to find a radiologist to look at your to be able to do a peer review. This might be just an OPPE, it might be an FPPE review, it might be more in depth, it might be just your annual cycle. You need to make sure that you're peer reviewing somebody. But let's see what a new process could look like. So imagine you log in somewhere and you've got a few reviews that you're doing externally, and you can see all of them on a nice little dashboard. And you can see where you have to react to something, where you're just waiting. But let's create a new request. So maybe this is something more serious. This is a mortality review. And I'm going to enter some information. Why am I requesting it? What's being happened, when it happened. What kind of specialty am I looking for, right? So pick your specialty, it could be hundreds. And, a little bit more information on what I'm requesting. And then I am going to upload a bunch of records. I'm going to upload some PDF output from my EMR system. I might upload some radiology imaging. I don't have to send it. I don't have to send CDs or papers. I don't have to fax anything anywhere. Just real simple. I just put everything up into this website. And then what I say is I'd like to match with an expert. And instead of me going out and spending the next few weeks or months looking for a doctor that's willing to spend the time to help, by the next morning, I get a little alert that says you have some CVs to review. And I come in here and I can start looking at some of these individuals that are really ready to help me, right? And I can see that they've been rated, and that's all really, really convenient. I decide that and by the way, I might share those CVs with my medical committee and say, hey, Dr. Evelyn's available, and we can move forward with her. And if I pick her, if you guys have ever driven in an Uber, Dr. Evelyn, a lot like an Uber driver, except she's not sitting in a car, she's probably sitting in an OR somewhere, or she's in clinic. She gets a little ping on her phone and it says, you've been asked to review this case. And she gets to see the basic information, and she gets to decide if she's available, if she can accept it. And if she does, then she can start doing her work. It's sort of ready to go. She may have a question that she needs clarification on. Maybe there's a missing file or a missing record that she thinks would be important. Maybe I want to talk to her, and I can actually schedule a time to discuss with her. But in the meantime, she's busy working on the report that I need her to fill out. I decide, hey, yeah, let's have a call. And maybe I invite my entire medical committee to this call. Maybe I want to invite other folks. Maybe it's just going to be her and I. And we'll talk through it. And we'll both get, calendar invites with a Teams or a Zoom link on it. And we'll chat. We'll chat through the case, right? And maybe she's delivered her report before then. Maybe she delivers it after because I want to talk to her first. But it's really flexible. We have a nice conversation. She gives me the real clinical perspective, right? She's 10 years or more practicing. She's very knowledgeable in her specialty, and she's clinical. So she's really, she's doing this every day, and we have a really substantive conversation. And she gives me a really good feedback, not just a rubber stamp feedback, but here's her thoughts and her ideas. And when we're all done, I come back in here and I review, what she said. And I say, okay, this has been great. And I come back into this website, I download my report, and then I rate her. just like you rate your Uber driver. Hey, you know what? She was amazing. Very, very helpful. And I click submit. The things I didn't have to do is I didn't have to get a contract with her. I didn't have to get an invoice from her. I didn't have to work out payment with her. I didn't have to do any of that stuff. It's all automatically done. I just got straight to what I needed, which was a qualified physician looking at my case with me. So that's just a glimpse of what Medplace does. And that's what we brought Terri here to talk about, because Terri is sitting in a lot of your chairs right now too. But Terri, what can you give us a little bit of your background? Are you with me, first of all?
I think so. Can you hear me?
I sure can.
Okay, good. Yay. Sorry about that. Yeah, my name's Terri Schimmer. As Jerrod said, I'm an RN that has worked at a critical access hospital my entire career. We're located in Cherokee, Iowa. Population's a little under 5,000, but small facility. We had 5 family practice physicians and 5 ER providers on staff. And I most recently worked as a patient advocate and risk manager, but was charged with overseeing peer review probably for the last couple years, and found it to be a struggle for us. We were affiliated somewhat with Unity Point in Sioux City, Iowa, a larger facility that was had always given us some support with peer review, but our go-to physician that we often used was given different job duties. And so it got to the point where it was just really difficult to even track him down and get a response, and let alone, do a review for it. So we kind of relied heavily on internal review. But again, with being a small facility, we just struggled with really good information, because these guys and women work with each other every day, eat lunch together, and so it was really hard to peer review each other. And so they just tended to be really soft reviews. It wouldn't be uncommon for me to get one with just no concerns, was the report that I would get. And it just, I guess we just needed more. And certainly when we had our facility survey, that was about the last thing the surveyors talked to us about was, how do you know that you have quality physicians when you go to credential and when you go to renew their contracts?
Yeah.
Excuse me. And so we got through the survey, but we knew we had to do something different, and we just needed to do better. And so that's when we were recommended Medplace, and we took that route and worked with them this year on peer review. And I guess I can support everything Jerrod has said, because it is exactly how he has presented it to you. It's been very easy to request a review. It's been very easy to just upload the documents, put in the request, send them the documents. Choosing the provider that was going to do the review was really great, and easy to do as well. And then I actually used the same provider. If it was like a hospitalist, I was able to use him again and again, for our facility, because
to create some continuity there. Yeah.
Yes, exactly. We did the same thing, I think, with an ER review, that we used that reviewer again.
Yeah.
So that part was really great. But I guess the big thing was just how quickly the turnaround was. Like Jerrod said, maybe a week, or sometimes maybe a few more days. They maybe just send you a chat that they need an additional report. You just upload it, send it back. But the reviews themselves are just so rich and so detailed that they really gave a whole new input for that provider. We actually had 3 new physicians in the past year that have just started their practice. And so I think we really owe it to them to give them good quality feedback. As Jerrod said, you don't want to wait till something's gone wrong, and then hit them up the back of the head, and kind of say, well, look at here, but we've done some quality reviews, just reviewing, like a sepsis case or that kind of thing, just for just the quality of the care that they gave. Some of the things in the review, besides just, did they meet the standards of care? What, was their medication choices correct? I would have done this, or you could have thought about this. But they also talked about documentation by the provider, which I thought was really a good thing to talk about, because I think we all know some of our providers are very detailed, have excellent documentation, and some aren't so good at that. But, they basically would say to them, if this chart would ever get challenged, they encourage better documentation in certain areas. And so just lots of good information, and the fact that it was from an unbiased eye outside of our facility, I think was really valuable. I mean, docs can get kind of defensive about all of this, but I think they got better as we went along, and we actually had some that were, recommended to go to peer review committee, which we hadn't had that for a long time, because I think, when you're working beside somebody, you don't want to make that recommendation, but we've had a few of those, and they were excellent. It was all of our medical staff is part of that committee, and just good discussion. And I think in the end, better care. I think everybody took something away from those meetings, and so ultimately that's what we wanted.
Terri, that's something, the better care, it's something that you and this starts at the leadership at Cherokee, the CEO,
Yes.
and you guys really have a philosophy for better care, and you seem to be really intentional about what that means, right? And even if it means doing hard things, you seem really intentional about that philosophy. Right.
Our CEO, I mean, quality is just a high priority for him, and I would say probably historically we probably haven't spent a lot of money on peer review, and again, like you say, some of the things that we did externally, we didn't get our reports like for 4 or 5 months. I think one facility never even billed us because it took so long, to get the information back. And I think they must have just said, well, we're going to give you a freebie here because this wasn't very good. But we definitely, we committed, a fair amount of more money in the budget for external peer review. And as far as I'm concerned, it's been well worth it.
That's great. We talked about this, whenever a position is being reviewed, right, in any environment, it can be a little bit contentious or awkward, something like that. How did you mentioned a little bit of this already, but how did the doctor sort of react to, some of the information coming out of these reviews? What was that like?
Well, I think, you mentioned that it's kind of uncomfortable for them, I think, when they know that their care is being reviewed. And even if it's internal, there's a little bit of a discomfort to it. But I just feel like it's been better since we've been doing the external reviews. And the information is just really, really good in the reviews that we've gotten. And I think the way that they have stated things that could be done differently was tactful, and I just think a lot of how they put it did not make them feel like they were being punished or I mean, I think it was just truly from a standpoint of, you might want to think about this, or I might have done this, and consider this. And so I think that helps a lot with the defensiveness, and and I think the peer review committees that the meetings we had, they were really good. They all talked together. They, basically, and even the physician that maybe the concern was with, when they actually came to the table for the committee, they had done some good thinking on what they should have done differently. And so, I mean, I think I don't know, I felt like there was just it just kind of grew to be a much better attitude about it. And I think they understood the reasoning we're doing it, and that it's quality and the patient, what's best in the long run. And that was our goal. And I think they crew to understand that, I guess.
Yeah. Did it help? Because I assume you did this, sharing the credentials and the backgrounds of the people doing the reviewing. Did it help when they saw who had reviewed them and sort of their background and, that they were, shared their specialty and things like that? Was that also a helpful mitigating factor?
Yeah, I think so. And I even when I mean, I was the one that chose them, on the front end, but I usually tried to kind of look at their resumes and as far as what their backgrounds were, and maybe even where they had interned at or whatever it might have been, if it was maybe similar to us in some respects. So you kind of try to match that a little bit. Yeah. But I think also the fact that we used the same reviewer, they got to know that name, and so I don't know. I think I don't know. It just definitely was more accepting to them, as we went along, because it was just external review, unbiased, just looking at the care and, providing their input. And it just, I think, really overall has gone very well with our docs.
Amazing. Well, I love to hear that. And, these doctors doing reviews are themselves doctors. They've been in the same shoes. They are in the same shoes as your doctors. Sure. And one of I told you this early on with Medplace, we had like two defining principles, and the first is empathy, right? So if you build empathy into the process, you right. inevitably get better outcomes. Right. Well, this was great, Terri. Amazing to hear the story. Thank you for kind of walking us through that. I do want to open it up for questions. See if anybody's got any questions. Right, you can enter them into the chat, I assume, Nestor. Or are we a small enough group that you want to turn it on? How do you want to run it from here, Nestor? Because I know we also have some of the polling questions as well to tee up again.
Yeah, we can drop the questions into the chat for the time being. I can give access to anyone that wants to ask the question. Just raise your hand in the when you highlight over your own name, and then we can go ahead and give you access. So either way, if you want to open up the mic, just raise your hand and I can do that, or you can drop it into the chat.
Perfect. While we're waiting for some questions to come in, if there are any at all, do you want to open up the polling QR code again?
Yep. Let me pull that up right now, and then.
Great. So if y'all haven't done this before, hopefully if you've ever used a QR code, you usually just open up your camera app and kind of hover it over that thing, and it'll open up a little URL and it'll take you to the questions. But if you're not that fancy, you can just go to menti.com and you can punch in that little code there, and that will take you to the same place. So we'll leave that up for a second. Also, let some of you answer some of those questions. See how many of you are brave enough. Don't worry, it's anonymous.
Yep. So we'll give you a few seconds here. We'll move on to the next screen in a bit, and then you'll start seeing the ability to answer each question one by one as we go through them. All right. Let's go through to the next. I'll give you a few seconds here to file in. And let's go ahead and go to this first question. What department handles peer review at your organization? And we put a couple of options there. Feel free to drop any other answers into the chat.
Yeah, that's looking like a pretty expected distribution.
Okay. Let's go on to the next question.
I would say that's one thing about peer review is often it doesn't have an owner or an explicit owner, and I think that's why you see it gets left behind sometimes.
or it gets passed around a lot.
Yeah, well, that's, I mean, that's part of your story. Didn't you inherit it, Terry, from?
I did, and I think it had been around the horn to quite a few people before that. So
Yeah,
yeah.
Kara mentioned for question 1 that the quality team at her organization does peer reviews with the help of medical staff services. So that's also very interesting.
yeah, yeah.
Mm-hmm.
Yeah. So needs improvement in average, I think very typical responses, right? So I think we all wish it could be a little bit better. I have to tell you, I talked to a lot of hospitals about their peer review process, and most of them are average or low, is how they would self-report.
Mm-hmm.
There's one hospital, I won't mention them, we've all heard of them, that is just amazing. They purposefully and always do like a very large percentage of their reviews externally. They're very proactive. It's extremely well run, and the physicians involved are very, it's not a punitive process at all. In fact, it's almost a cultural process to see how can we identify. You get points for identifying where you can improve things, right? And anyway, it's just really amazing. And I would consider them in the top, 1% of programs out there, but it's really exciting to see something like that. But most of us aren't in a situation where we would say that we're at that kind of level.
I would support what you say there, though, Jerrod, about it's a cultural thing. That if you can get your providers to feel that and think that, it shouldn't feel bad to them at all.
Yeah, that's right.
It's really meant to support them.
Yeah, it should be energizing. They should feel like they're, and I'll tell you this, if you want your doctors to be better doctors, have them review other hospitals, have them participate. If you have doctors that want to participate on our network and review others, there's nothing more fascinating to watching a doctor who's actually being reviewing for somebody else and like in a really substantive, meaningful way. It's really, and they'll always come out of that and say, I'm a better doctor for having done these reviews. So if you could change one thing about your peer review process, what would it be? No answers yet. I'm on pins and needles.
One thing that I would share real quickly too, Jerrod, is the weekly touch point that we did with your team when we started, because it was very supportive. I mean, it wasn't like you just signed up for it and then away you went and tried to paddle through it by yourself. But we met weekly with 3 to 4 people on the team and talked about how it was going, and they gave me some input about what I was sending for information. That was great.
Yeah, I get asked, Jerrod, you're a technology person. Why do you have so many people involved in it? And I tell people, like, technology does not replace people. It only should sort of get out of the way, get things out of the way so that people can do their work. But yeah, when you're dealing with something like peer review and going through a new process for the first time, having a friendly human and people with clinical backgrounds on the other end that have done the same job, and they've been a risk manager and they're RNs, like that's really important in the whole process.
Yeah.
Okay, we got some good questions. We have some good answers here. Let's see. Let me read a couple. So things that you would change: cultural communication change. Have every physician not only aware that reviews are occurring, but openly inviting the reviews. Yes, that's that cultural change that we talked about. Higher quality review from internal physicians, right? Exactly what you were saying, Terry. You get these sort of rubber stamp reviews that aren't helpful. Providers not afraid to give honest review of their peer. Yeah, I think that's the part that I think when we talk about system design, it's an inherent system flaw if we're asking humans to betray their social selves, right? This is like you said, I have breakfast with this person every morning, and to ask me to engage in a system that requires me, socially to put myself at risk, like that's just a hard system design thing to get over. Standardization in reviewing cases proactively before issues, events arise. So this is huge, right? So creating standards so everybody kind of knows the rules and the rails have been laid. And so that when you do these reviews, everyone kind of knows what goes in and what comes out, right? Is consistent. Like the rules are fair. The amount of reviewing that's being done is fair, right? Like that's such a huge part of creating a process that physicians can then get behind, right? And that they can buy into as not punitive, but proactive.
Right, right.
Here's the next one. Having enough hours staff to do the job. Easiest ways to redact charts, right? So just having enough people to do everything. Providers
I
not,
will say though that this saves time though. I mean, it really, you mentioned that, trying to find somebody that could do the review and making those calls and calling them back again and how much are they going to charge? And there's a lot of time that just goes into trying to get one review done. And this was just so slick. It really was.
I say we've built the Uber for physicians.
Yes, I think
my
so.
doctors aren't driving people around, but Uber's interesting, right? It's a lot of really hardcore technology that's presented to us in a really simple way, and it demystifies the process, right? I can see my driver approaching and things like that. Once you create something like that, it becomes much easier to, decide, hey, I'm going to get a ride versus drive somewhere. Providers not finding a review process as punitive or negative, right? Any other advice there on that one, Terri, as far as like, because I know we're all in a journey of getting to that point, but any advice?
Well, I think that will come. I had one provider that, we told them that we were doing this and that we had an external review company. And so we felt like we told them we'd be doing this. Well, then we did a quality review on a hospital stay for one of our providers. And he got a little bit, sensitive about it and defensive. And you should have told me you were doing this. And I said, calm down, sit down, let's talk about this. And I mean, he had some recommendations on his documentation, especially. And, I said, they haven't sent you to committee, but just take what they've told you. And pretty soon he was like, I do need to do better with my documentation. And, he finally kind of was like, okay, yeah, they're probably right. And so I think that you kind of got to work with them a little bit, but I think we just were slowly seeing a better feeling about the whole process.
That's amazing though. Willing to go through, and that's a decision that comes from the leadership there, is you're willing to go through hard conversations to get to better quality, right? And that is so essential. And I love that.
Yeah.
Let's see, Kara said, helping providers understand and embrace peer review. There are several non-standard practices that we use, and we attend webinars and conferences to learn peer review, but it's not our, quote, our process. So we give them the information on how to improve the process and make sure we have non-biased reviews, and the information provided is not taken into account, right? So it's falling on deaf ears in the way that it's being delivered. And of course you said, and also everything that everyone else is saying. It sounds to me like maybe having those substantive conversations with the reviewer who is an expert in that specialty and can have those like conversations like you're used to having now, Terri, where they're just very productive, right? And yeah.
Yes. Well, and I would say our most senior physician at our facility, he could probably work for you. He does excellent review of cases, and he actually was very good at supporting all of this as well. So sometimes if we did have a defensive provider or that they just were not taking it real well, he was more than willing to, and he's a calm guy. So he often was a good voice of reason. So if you even could get one provider that just is kind of a champion for it, that helps tremendously too.
That's great advice. And I expect his CV in my inbox by this afternoon. We always need good doctors.
Yes, that's true. He'd be good.
Oh, we have more questions. Is this the last question, Nestor?
Yes, I believe so.
Okay, how many of you have done an external peer review? If so, how many? And this is probably what, like per year? Is that the time frame we should say? How many of these do you do per year externally?
Yeah, I think that's fair.
Okay, we'll give people a chance to respond. By the way, it's not uncommon that there is zero, right? I've seen it. We've done whole webinars where it's just because it's so hard to do when you need to
Yes.
do it. Well, somebody did 10 externally, so you're already beating the
Good job.
curve.
Curious if any of the answers are, especially the 10+ response, is that a monthly, or if you can give more context to what that looks like, that would be interesting.
By the way, Nestor, I don't see the option of 0 on here, so it's very possible that people don't have the answer that they can't give the answer that they want to here.
That's a good question. That's a good point. Yeah, if the answer is 0, feel free to drop that in the chat as well.
Because that is the most common answer, just so everybody knows. So in case you guys are wondering, are you an oddball or anything like that because you haven't done these externally? You're absolutely not. Yeah, Kara, 1 to 2, good. Got another answer, 5 to 10. So good. Good to hear that this is being done. Well, I think with that, gang, I think hopefully this has been a productive hour. If nothing else, hopefully it gives you some inspiration as far as what you might want to take back to your leadership or your medical committee. But if you ever have any questions, you can certainly reach out to Medplace. You'll get our contact information afterwards. And of course, I think everyone here might have a relationship with Constellation. You can always ask any of your contacts over there. But I do hope that you enjoyed this. If you ever want to try this out, it's very, very easy. You can just, order a review and through our platform, and we can show you how to do it and have humans help you along the way. But I hope that everyone does keep leveling up as far as your delivery of care and quality. And Terri, I just wanted to thank you. It's always good I didn't get to see your face, but it's good to talk to you.
No, absolutely. Great program.
Appreciate you being such a great partner and everything that you've done at Cherokee. And now I think if everyone didn't catch this, you just recently retired as of July. So now you're taking care of grandkids and enjoying life.
Yeah, yep. Slowed down a little bit. So
Yeah,
it's been good.
good to see. Good to see.
Yeah, thanks.
All right. Well, thanks everybody, and look forward to meeting everyone over time.